Okay, today we are going to do gingivectomy from mesial of 27 to distal of number 22. A situation that before you decide to do the gingivectomy, you have to make sure you have enough keratinized tissue. We are assuming that we have enough keratinized tissue, and we are assuming that we don't have a high frenum attachment that we need to take care of. So the first step on the gingivectomy is marking on the outside part of the gingiva the bottom of the pocket. This gingiva is made with silicone, and it won't be firmly attached to the bone. So you will have some limitations in terms of doing a fine and neat incision. The tissue may tear in between the teeth, or the silicone may tear in between the teeth. So those are the limitations that we may encounter using this kind of typodon. But for today's exercise, we really want to do to understand the principles of this type of procedure. So the first thing that we have to do in a patient will be transferring the bottom of the pocket outside of the gingiva. In this case, the bottom of the pocket is located at the crestal bone level. However, for today's exercise, we will going to consider the bottom of the pocket located about 1 millimeter coronal to the crestal bone. So what we do is, in a real patient, we mark the 6 millimeters and we just do this. When we take the probe out, the gingiva will start bleeding. Obviously, in this case, won't happen. So what you want to do is, instead, go 6 millimeter mark. We mark it outside like that. So we are going to have a little point in there. And obviously, we are going to do the same thing on the proximal area. We go all the way to the crestal bone. We go back up 1 millimeter, and that is just for the typodon. In a real patient, you just go to the bottom of the pocket, and you will do the same thing on the buccal side, on the distal side, sorry. So basically you are going to have points Once you have the bleeding points, you can see that there is an outline of what kind of incision we are going to have. These are the center of the buccal surfaces, on the zenith of the teeth. The problem that we encounter in this one is this very typodon in this area has the bony defect is uneven. The bone surface is not flat 100%. So in this area, for this very typodon, and some typodons may vary a little bit, the crestal bone is located more apically for this tooth compared with the rest of the teeth. So we are going to have kind of an uneven festoni of the gingival tissues as a final result. So what we are going to do is, starting with the Kirkland knife, the part of the knife that actually will do the gingivectomy will be this one here, and we are going to go in that direction. Kirkland knife, as you see, has an inclination, and this inclination will bevel the gingiva. Big deal for us. When we turn this one around, and you see that the tissue, when we go with the Kirkland knife, the gingiva will start having some sort of beveling, and then we are going to finish the beveling with other procedure, complement with a final procedure. But the initial incision already is going to be with external bevel, and the Kirkland knife helps us to achieve that much easier. So we are going to start the incision on the canine. And we are going to go from distal of the canine, we are going to go all around until we go to distal of the lateral. So we go like this, right at the level of the bleeding points.
However, in a real patient, the incision should be apical to the bleeding points.
Remember having the critical knife with the proper inclination, and be patient because the silicone won't allow us to work that easy. We go and we incise right at the bleeding points, from distal of the canine to distal of the lateral. And sometimes you may need to review this incision until you achieve the full cut. So we have one incision completed. The second incision will be from here, from distal of the lateral to distal of the central. And again, we are using the bleeding points as reference points for us.
Remember that in a real patient, the incision should be apical to the bleeding points.
And we are going easy and deepening the incision until we make contact with the teeth. Both teeth, lateral and central. So we have two incisions. Now, next incision will be, again, from distal of the central to mesial of the central. And we start at the bleeding point. And because these are lower incisors, the amount of room that you have is very limited. So you really want to go slow. And don't stress much if it has a shape that you are not entitled to have. You may rectify that later on. There. Now the third incision will be from mesial of the central to mesial of the lateral. So remember, these are the bleeding points that we are using as a reference. If they are disappearing, you just can add them again. From mesial of the lateral to mesial of the canine. Always keeping the angulation that the critical knife is giving you. So you are doing that external bevel incision. And finally, you are going to do the last incision from mesial of the canine to mesial to the premolar. So in this case, I lost some of my bleeding points, which is added in order to have it as a reference point. There, and now we have all the incisions that we need to have at least the original incisions. Tissue separated in that sense, and now what we need to do is separate the tissues in between. So in order to do that, you can utilize different instruments. You can utilize the Kirkland knife, to do the incision with this portion of the knife and separate the color from the papillae like this. So you're using this knife, so you're achieving that separation. And go easy, because this silicone won't let you work that fast. You can also use the Orban knife. The Orban knife will be used in this direction, and the Orban knife has two cutting edges, so the only thing that you have to do is just go in with the Orban knife and cut the tissue like this. There. And the other option that you have available will be using just the Brad Parker knife for doing the very same procedure. Just cut the papillae like this. And we have the very last one. The very last one, we can do it also, if you want, with the Kirkland knife. So we are using all the instruments that we need to use. So we will have now this kind of situation, but when you see the gingiva from the side, you will notice that the angulation of the incision is like this. So the emergence profile is like this. So you really want to have a flatter emergence profile. Therefore, what you are doing in a real patient will be using the Kirkland's knife and go with a knife like this, and you are going to end up beveling the tissue. Doing this on this type of them will take you forever. You can also use the Brad Parker knife, but in this case, because you have the lower lip, you are not going to have this kind of access. You may need to have probably this kind of access and beveling like this. So you're better off using the Brad Parker knife, sorry, the Kirkland knife, to bevel the tissue, and it will take some time doing so. So for this exercise, what you can choose doing is instead using the Brad Parker knife and just giving to the gingiva a nice emergence profile. So you are going to dissect the gingiva in a way that gives you the emergence profile. You are sculpting the emergence profile that you really would like to have. So go easy, little by little, and have that final sculpting. Make sure you don't destroy your papillae. So the only thing that you really need to do now is doing the final touch-ups on the gingival tissues and make them look pretty. Make sure you don't have nothing that you really don't want to have. Making the gingival architecture a little bit more harmonic. Alright, so usually you may want to give the final touch-ups with a Kirkland knife like this. And you are going from a situation from here to here.